All right, everyone, if I can ask you to come back in and take your seats, we're going to get started on the second panel.
Hey, John.
Okay, so our second panel today is focused on the SMGL partnership, cost effectiveness and sustainability. And again, we will have questions and answers at the conclusion of the discussion of the panelists. So thank you again for all of you for being here today, and thank you very much for our speakers and our moderator. I am going to turn this over so we can try to stick to our times. To our moderator, Robert Clay. Robert is the Vice President of Global Health at Save the Children. Robert, over to you. Thank you all.
Thank you, Sarah, and welcome to all of you here. I feel really great to be with our SMGL family. Some of you may know that I was involved early on when the program shifted from the State Department over to USAID. And I was real glad that Claudia mentioned some of the challenges that we had, because I was afraid you would walk away thinking this was an easy thing to do. And it looks so nice when you see it up on the PowerPoint. But the sausage looks great, but the making of it was real challenging. And particularly the funding issue. I think that there were times when we weren't sure whether we would be able to sustain the staff in the field. And so this idea of trying to prove yourself and then wait for the evaluation to come back and then to try to more resources, I would not recommend that to anyone. It did incorporate, I think, a very important principle about partnership. And I think in that way it was very much like the PEPFAR whole of government approach. And we had lots of really good partners that we were able to work on. And we'll hear more about that in this panel. But in many ways, it was quite different than PEPFAR. I was involved in PEPFAR, and the funding was quite significant, and just the certainty was different. And so I really think that the people working on SMGL, they demonstrated time and time again their devotion, their passion, their hard work to get us to where we are today. And certainly Claudia leading the charge over the last several years has been a real leader in to getting the published document. It's very easy to say we're going to have a journal, peer-reviewed journal. It's very difficult to lead all those cats to that point. And so a big congratulations to you, Claudia. And Claudia mentioned Marge Kablinsky. In my career, she was the sort of the leader, the epitome of maternal health, along with Mary Ellen Stanton, who really were fighting for this throughout, the 1980s, late 1980s, the 1990s, and we were just really dumbfounded why this didn't pick up. What was wrong? Why didn't maternal health issues? Why didn't that have the same gravitas as some of the child survival work, and then later on with AIDS, TB, and malaria? And some of it might have been that we didn't have a champion like those other causes did. Some of it was the feeling that it was very intractable, that it was difficult to do. But I think a major part of it was the lack of evidence and the lack of data. And I would say that what SMGL has done is contribute to this evidence base. It hasn't solved all the problems, and I was glad to hear that this is not being presented as the utopia. It's being presented as a really focused attempt with lots of good minds to see what was possible within these countries. And so I think that is real. That's a huge contribution to the field. And hopefully, through this meeting, the dissemination through the journal articles and subsequent discussions, others will pick this up, pick up the themes, pick up the optimism, the fact that we can do something about maternal health. It's not something that we just have to accept. As some of the comments earlier saying that in these countries, people just assumed this was going to be the future, that women would die because of these complications. And now we've changed that mindset. We've changed that way of looking at maternal health. And I think that probably is the most important thing, because then people have hope and they have a vision of where they can move. And this is moving many people. We've heard about what's happening in these countries with governments, with other donors. And so we are hoping that this will be a benchmark for others. I just returned last night from Mali, and it was interesting to be there for the last week of looking at a country that in many ways has similar statistics as a lot of these countries did in the 1990s. Maternal mortality, MMR is over 500, child mortality is over 100. And I was thinking through my trip of how they could benefit from what we've learned in these two countries. So it is very relevant to our world today. And as we move into, looking at that 2030 vision, I think we need to really read these papers, learn from them, adapt them. You saw each country had different ways of approaching this. And so we need to adapt it, but keep the core knowledge that I think this project represented. So to help us move that knowledge along, this session is going to be talking about three important areas: partnership, finances, and sustainability. So this is really, in many ways, what's the future? How do we make sure that these successes that we saw in the first panel, how do we continue to have this as a gift that keeps on giving? And to do that, we have three distinguished panelists, and I will introduce them and then ask them to make their presentation, and we'll go through the same format of having some questions at the end. So first, to help us think through partnership is Ann Palaya from USAID. Ann is the Senior Evaluation Advisor in the Global Health Bureau. Next is Ben Johns from APT Associates. He is a Senior Associate and Scientist at APT. And then finally, Dr. Marianne Iberte, who is the Executive Director of Merck for Mothers. And all their background and CVs are in the documents that outside. If you haven't gotten those, you can find that. So let me turn it over to Ann and have you share with us a little bit about partnerships. Clearly a critical part of this program and how it was able to succeed, but also one of many challenges and lessons that we've learned. Thanks.
Thank you. So I literally just parked my car. I have a 4-week-old, and I'm on maternity leave, and I've left her alone with my 2,000-week-old, and I'm scared to death. I'm hoping both of them are alive when I get home. Yeah, so it's interesting because I had challenges during my labor, and I was reflecting with my obstetrician afterwards that I probably would not have made it if I didn't have the interventions that I had available to me, and my child definitely would not have. And she's perfectly healthy now, and so am I. So the work that's being done here to bring this this kind of support for women and children around the world is critical. So what we did is, so I'm an evaluation advisor with USAID. However, I had no role in SMGL prior to being asked to support this qualitative evaluation. So in that sense, that's a level of independence we had. The team that we worked with on this particular qualitative study, none of the members were fully engaged with SMGL prior to this study, and we tried to maintain some sort of autonomy and independence throughout the entire process so that we could get, it's a qualitative study, so there's not, well, so that we could get valuable data. And I'll talk about it a little bit. We interviewed 57 individuals who are partners in the U.S. government, in partners in the SMGL partnership from the U.S. government here in Washington and in the field, and our global partners like Merck for Mothers, et cetera. We invited 57 individuals to interview in Uganda, Zambia, and the United States, and 46 participated. And we were trying to get at, basically, in short, the strengths and limitations of the partnership in terms of achievement of the goal of a reduction of maternal and newborn mortality. And this had been undertaken 5 years ago or 5 years prior by Columbia University Group, similar. So we were sort of trying to follow on at the end of this project to see how things had changed. What we found was that this particular partnership was very supportive of the overall goal, and you've all probably already heard today the incredible success that has been achieved, that is sort of unprecedented, and has a lot to do with these particular partners who all came together, their diverse expertise, their uniform commitment to the cause, and their support for, I guess, infrastructure development and careful monitoring and evaluation so that we could improve the process along the way. Hopefully you'll have the chance to read the paper, but I'll give you, I think qualitative studies lend themselves better. The reason I don't have a PowerPoint is because you really just want to hear the voices of the people. So, for example, a respondent from Uganda, a district health office, said that a lot of infrastructure improvements have been done and equipment. Those can probably stay longer, maybe 5 years or more. A lot of capacity has been built of the health workers, and a number of them have been taken on by districts of the government of Uganda. They've been put on the government payroll. So I believe that with that, knowledge has been passed on to them. This is something that can stay in the long term. And that's what's really, honestly, critical about this. When we leave, what are we leaving behind? How sustainable are these sort of partnerships and interventions? The other strength they had was that a lot of ownership was given to the district health offices. And so they were able to feel like this was something they were doing. It wasn't just USAID coming in or Merck coming in. It was something they were making decisions. They were coming together and choosing how to allocate these resources. And one particular respondent in Uganda, district health office, said, partners have not done activities in the districts without consulting the DHO, the chief administrative officer, and with the chief administrative office, the district executive committee. And monthly, there have been project coordination meetings, and that makes us own whatever we do that we're implementing in these areas. So I think that is a real success and something that is really challenging. Both of these things are challenging to achieve. So I don't want to keep droning on, but I will answer any questions, I think. I'm just giving you a snippet so that you'll read the paper.
Okay, thank you, Anne. And I think your comments about how partnerships are really, or ownership, I should say, ownership is really essential for partnership if they are to be successful. And I think that goes at both the global level as well as the local level. And the other thing that I think was important in SMGL is the fact that roles and responsibilities were clearly defined. Because in my experience, where you spend all your time in partnerships that don't necessarily work is trying to mitigate between those two, between organizations that see themselves doing similar things, and that's can be a very big issue. A big question that always came up when I was engaged in the project is, great, you're showing good results, you're having terrific impact. How much does it cost? This looks pretty high end. I mean, we had lots of evaluation up front. We had lots of services and activities that I think a lot of people would say, well, we can't afford that. We wouldn't be able to do that. And that's some part of a pilot where you are trying to determine whether it works or not. But Ben, help us lead through. Are you leaving or what? I didn't mean for you to be scared about this, but please take us through this issue of cost.
Oh, thank you. All right. So there's a long title. And I hold no illusions that many of you will read this paper based on the title, but you can do it. And there's a lot of authors, and obviously many, many more people than the authors contributed. And I'd like to thank them first. And then I'll say when I was in grad school in public health, most people were interested in things like saving lives and whatever. Not very many people were interested in bean counting. So sometime around 2016, Claudia called up the Health Finance and Governance Project and said, we need cost effectiveness analysis. And that is fairly unusual, actually. And she may still be regretting that day, but here we are. So what we're trying to do with cost and cost effectiveness is, so first, how much did SMGL cost in total and per delay? And then the second question is a little more complicated, but I'll try to walk you through this. I'm assuming everybody here knows about maternal health, but knows less about cost effectiveness. So I'm going to dwell on cost effectiveness. But we want to know, for this study, we wanted to know how much did it cost to prevent a death, and how much did it cost per year of life gained. So year of life gained means if a newborn dies and they have a life expectancy of 69 years of life, were then gained by preventing that death. Because health economists are very economical, we don't like the word of, so we call those life years. If I say life years, translate back to years of life. So, methods. This is my only slide on methods. Like epidemiology, we need a counterfactual. Counterfactual is an alternate reality where SMGL never happened. In this reality, SMGL happened. We want to compare those two realities. So this counterfactual, for the effects, we took the numbers from CDC, and then we took the 2012 numbers from the SMGL districts and used the 3% per year. That was the national trend, for example, for maternal health, to adjust them up to 2016. And we say that is how many deaths would have occurred in 2016 without SMGL. For cost, we went to SMGL districts, we costed some stuff, and then we went to a comparison district where there was no concerted effort to improve maternal mortality. We couldn't do that with effects because SMGL did such a good job collecting data on deaths that we couldn't find anywhere else that had reasonably good data. Okay, this is my fun slide. So this is what happened in Uganda with SMGL. They spent about $1.5 million per district per year for maternal and newborn health. This is all in, government, donors, everything. If SMGL hadn't happened, it would be about $650,000. So 3 or 4 points here. So the difference is what we're really interested in. SMGL cost about $850,000 more than what would have happened without SMGL. Second point, these colors are the different breakdowns. First delay, second delay, third delay. And as Claudia mentioned, there's some health system strengthening M&E costs that don't easily get packed into a bucket. So we see in the counterfactual, there's almost nothing going on for the first 2 delays. In SMGL, 20 to 25% of costs are for the first 2 delays, which isn't actually, 20%, not so bad. Second is, well, costs for clinical care basically go down as a proportion of cost. The length of the bar goes up. So more money was spent, even if it's a smaller proportion, more money was spent. Why? More deliveries at facilities, consume more drugs, etc. Plus, so increase utilization, but also increase in quality. So women show up, they actually get the drug to carry on the drug exam. Same slide for deaths. Without SMGL in Uganda in one district, about 621 deaths on average. With SMGL, about 540. So the difference is a little north of 80. 80 deaths prevented. And for Zambia, about 60. Put them together, this is what you get. Roughly $10,000 to $12,000 to prevent one death. $175 to a little over $200 per year of life gain. Yay. Okay, so what? Who cares? What does it mean? So the question we're asked is SMGL cost effective? So WHO, very loosely, they actually talk about disability adjusted life years. We didn't include morbidity reductions in our effects, so we're conservative, meaning we're less cost effective than we would be if we had included morbidity. So very loosely, they say, if you're less than GDP per capita per life year gain, you're very cost effective. This is how economists think. Like, if a person produces $1,000 in a year, and you spend less than $1,000 to preserve that year, it's a good deal. Probably a lot of you aren't used to thinking about life that way. But recently, economists have said, actually, GDP is too high. Maybe 50% of GDP is cost effective. Doesn't matter, all right? We're coming in Zambia, just over 16% of GDP per capita. In Uganda, 25% of GDP per capita, well below 50% of GDP per capita. Based on this, we can say, according to WHO standards, this is very cost effective. SMGL was very cost effective. The cost question, affordability, there's no WHO standard, unfortunately. So we can just say in Zambia it was about $485 per person per year. In Uganda it was about $1.36 per person per year. So if you were to do these activities, I'm not talking about effects, but do these activities on a national level, you could afford this by paying less than 0.5% of GDP in Zambia and less than 0.25% in Zambia. That's all I got. Thank you.
Thank you, Ben, and you've been able to bring some dry humor into the topic. I think you have a big future ahead of you. But it's very unusual having this kind of information, I think, for programs. So I think SMGL is to be applauded for bringing in this perspective and being able to answer questions that people have often asked. So Marianne, the big question, sustainability. It's a big word. We hear it all the time. What's the perspective, particularly how the public and private and how it worked on the sustainability? So over to you.
Thank you. So, good morning, everyone. I think it's still morning. I'm the last speaker, so if you could bear with me. I do think, and I want to come back to the beginning of the meeting, this is such an important session to have because I don't think that we should underestimate the results of SMGL and the reinforcement of the health system strengthening approach. It's not only important to share these results because we don't often see population level impact, but we also need to have this conversation because of the question from the Twitter person who asked about what's the advocacy for replication. And when we have that conversation about replication, the two questions that people ask are, one, how much is it going to cost? Okay, so we got that answer. And then two, are the results sustainable? And so that's the conversation I'd like to have with you today. I also want to thank Claudia and the authors of the paper for having me up here to share some of their insights and perspectives. Merck for Mothers, did not participate in that paper. But I do think all of the partners shared a commitment to thinking about sustainability from the beginning of the project. And I think that not only spoke volumes to our faith, in the health system strengthening approach, but also about the change we wanted to see in the future. So before I delve into the paper, I do want to talk a little bit about what do we mean when we talk about sustainability. I think, I don't know how many people we have in the room here, maybe 80, we probably have 30 different definitions of sustainability in the room. Anne talked about it's what you leave behind. Some people talk about country ownership. Some people talk about the ability to continue funding. Florina, one of the things Florina mentioned about looking at continued outcomes, not just the maternal health outcomes, but we didn't measure morbidity. We didn't see progress in indirect causes. We didn't look as closely at neonatal outcomes. Those are things that have influenced how I think about sustainability. Claudia shared a theory of change, so I want to share with you my theory of change for sustainability. She had inputs, interventions, outcomes, and goals. I think traditionally we have focused on country ownership and funding when we think about sustainability. I put those squarely in the input and intervention box. We need to talk about outcomes. So can we sustain the outcomes that we've seen in the maternal mortality reductions? But that's not enough. That's not the higher level of the theory of change. The higher level, the goal. What is the goal? We need to continue to show and achieve progress because, as we heard, the 44% reduction is not enough. We are not yet at utopia, and there is so much more we can do. So the question is, what was the sustainability of the SMGL approach? So I'll share with you how the authors approached that question and looked at it. So the basic framework through which we looked at sustainability was built on the Sustainability Index dashboard that was created through the PEPFAR program. But we added something. We added an additional domain, which I think is really important, and I'll share that with you. The team conducted 86 key informant interviews from all of the districts in both Zambia and Uganda. And when I believe part of why they added that fifth domain was from the inputs of those interviews. So the domains, the first one, governance, leadership, and accountability. The second, national health systems and service delivery. The third, strategic investments, efficiency, and sustainable financing. The fourth, strategic information. And the fifth, community normative change. So basically, we're talking, do we have leaders? Do we have systems? Do we have money? Do we have data? And then last but not least, do we have culture change? And for some of you who have heard the saying, culture eats strategy for both breakfast and lunch. And I think that was, if you haven't, there's a saying, culture eats strategy for breakfast and lunch. And it's a relevant saying because what the paper found was that the normative change, the cultural change, was actually the most significant driver of sustainability and the domain that they saw the most movement in. So when you looked at cultural change, you saw men getting involved in this. You saw traditional leaders getting involved with this, and both of them saying, this is no longer just a woman's issue, but this is something we have to care about as well. And that there was a cultural change because we saw increased facility births, and we also saw a decrease in child marriage. We have continued to see a demand for these types of changes. And I think this relates to the point I was making about the higher order goal, because one of the early things that we're seeing now is that we've increased demand for these improved services. We've increased demand for the maternity waiting homes. If you build it, they will come. So we must make sure that we're able to continue to build and meet the demand for these new services. The second domain, leadership. Claudia mentioned that, in the ministries, they know before lunch if a woman dies. That transparency, that accountability, that disbursement of this type of information is critical. It also holds those leaders accountable to their constituencies, but that would not be enough if they didn't have the data to know what to do. And so that brings us to that third domain, data. And all of the investments that SMGL put into data surveillance systems, whether they were birth registries, death registries, the DHIS systems, and I think very importantly, looking at the maternal and perinatal death reviews. These are investments in data systems that we believe will have ripple effects for not just maternal and child health outcomes, but broad health outcomes for the community. The fourth domain, systems. All of those investments in health workers, whether it be training, mentoring, equipment, skill building, those, again, human capital investment that will have ripple effects. There were also capital investments in facilities. And when we talk about health system strengthening, one of the really exciting things that SMGL did was not just strengthen health systems, but it strengthened systems for health. So it also invested capital in electricity. It invested capital in transport systems and communication systems so that women could access those transport systems. Again, things that we believe will have ripple effects for other health outcomes. The fifth domain, last but not least, money. And I think, that always, becomes the critical question because unlike progress, money is a finite resource and we have to make decisions around how to allocate it. And so when we look at the context of money and financing within the sustainability framework of this paper, one of the things the authors conclude is that while there was not an increase in domestic resource allocation for maternal health, all of the partners, including the ministries and the donor agencies, were able to think about how to more efficiently allocate the resources that they had. So whether it is that on-ramp of using the World Bank's Global Financing Facility to support the funding, or whether it's to integrate components of SMGL into broader donor programs that address the broader continuum of health outcomes, these were ways in which the partnership sought to sustain financing for the successful components of the model. So I guess in closing, I'd like to say two things. One is to just share with you some of the leading indicators of sustainability. We talked about systems and how healthcare workers are important parts of the system. The Ugandan parliament passed a federal wage bill that provides incentives for the physicians to work in rural and underserved areas. So that's law, and that's law that has money behind it. The Ugandan Ministry of Health also assumed the salary cost of most of the workers that had originally been funded by SMGL. And they also rolled out guidelines to make the maternal mortality death reviews part and parcel of routine care. In Zambia, the Ministry of Health endorsed the SMGL-supported supervision model. So again, that is now standard of care, standard of practice in that system. and also updated their guidelines for the treatment of postpartum hemorrhage to include new innovations. So, in ending, just to say that when we look at the totality of our experience from SMGL, I think one of the critical things is the acknowledgement that women and communities need to be thought of as part of health systems or as part of systems for health. That, we believe, is what drove a lot of the change, especially that cultural change that we saw driving sustainability. And then the second point to leave you with is that, as I mentioned before, we can't just stop at sustaining the results that we achieved. We need to continue to accelerate progress. We're not going to hit our SDG goals for less than 70 maternal deaths per 100,000 live births unless we accelerate our progress by at least 2 times globally, and in some countries in sub-Saharan Africa by 6 times. So you get to ask some questions to us about sustainability, and I look forward to them. Thank you.
So I just wanted first to let you know that the slides will be made available on the Maternal Health Initiative website in a few days, so you'll be able to have access to that. But thank you very much, Marianne. And I would just add, in terms of sustainability, you know, as we started the program, we did a lot of, we went through a rigorous selection process for the countries to see whether these would be the right countries to try this initiative in. And one of the things that stood out, both Uganda and Zambia, is that maternal health was part of their national plan. So we built on their ideas. In many ways, if you talk to government officials early on, we were kind of helping them do what they had planned to do. So I think that is really key in terms of their ownership and their sustainability of this activity. This was not something that was imposed or dropped in on top of them. It was something that they had already envisioned, and we were helping them in that work. So all the speakers have been great. They're right on time, which as a moderator, that's your most important indicator. So we have plenty of time now for question and answers. And I'm going to just start with question to each of the panelists, and then so as we did in the last session, please be thinking of things that you would ask. But Anne, if I could start with you in terms of the research work that you did, what's the most surprising thing that you found? And then what are some of the key takeaway messages from the study that you would consider for when people are entering into partnerships, which is obviously a key priority for most of the donors in this community? Thanks.
Okay. The first question, what was surprising? Well, what was most surprising was that there was the strong experience of ownership at the district level, as I mentioned before. And it was one of the key advantages that a lot of the respondents in this category noted. But there was limited representation of the Ministry of Health at the national level within the governance structure. So there wasn't a perception of country ownership at the national level when interviewing Ministry of Health officials, but district health offices felt that there was a very strong agency that they had related to this partnership. And I think it goes into this leads to some of the key takeaways. One is that there needs to be engagement at all levels, I think, in order to, well, not I think, but we found there needs to be engagement at all levels in order to sustain the partnership activities after the partners leave. And among the takeaways, other takeaways included there are distinct agendas among and across these different partners. And having a champion to sort of align all of these agendas into one uniform goal was critical. I think a challenge in a partnership is that there's not supposed to be a sort of hierarchy. There isn't a leader. Everyone is supposed to be equally engaged, but without a champion, it was over and over again repeated in interviews that the champion that Claudia brought to the table, brought to the partnership, and other USAID members really helped to pull the various agendas together. So having a champion, the need for infrastructure support, and whether it's material or whether it's training, I think that came up quite a bit, and the strength and rigor of monitoring and evaluation so that you can adaptively manage the interventions and activities supported by the partnership. One other aspect that I wanted to bring up is that there was reported among different partners the perception of inequitable power. Some partners were big P partners, some partners were little p partners, some partners had a lot more perceived influence because they had more money to contribute to the partnership than others. And it ended up not showing to be detrimental to the success of the partnership in terms of achieving the goal, because of the strength of the champion and the leadership bringing the agendas together and aligning the partners.
Good, thanks very much. I just want to underscore this idea of a champion, because early on, I would say the champion was really Secretary Clinton, and this was a perceived high-level, visible initiative, and the whole year that we had to prove ourselves was very much driven by a political kind of mandate, and I think this was unusual for this program. But many of the partners, I would say, joined because of that political visibility, and it accelerated and highlighted, I think, the importance of this program. And it was actually a champion that we were always hoping to have for maternal health, and we were able then to hook it with the Secretary's ambition. So I agree, a champion can make a big difference in terms of opening doors and getting people to join on and moving forward. Ben, you presented some very compelling statistics. They looked quite solid. How confident are you in these? Because, having worked in the field, I know that what comes from the bottom is often not as clean as what you were presenting. So, can you give us a sense of what's the confidence intervals around some of this stuff? And then also, I know there's been other cost-effective studies that have been carried out. So how does this differ from some of those other studies? What does it add to the global knowledge?
Okay, thank you. I'm supremely confident. So, yeah, it's not a perfect study. It was retrospective and not randomized and blah blah, right? So what we did throughout was we tried to be conservative when we had to make a decision. So, for example, we didn't include morbidity, which makes SMGL look worse than it actually was. So throughout, we tended to err that way. And the second thing we did was when we had to make an assumption, we tested it. We said, what if this assumption is really wrong? And then we'd rerun all the results. And generally speaking, it always comes up under 50% of GDP. Well, the exception is like if we made every decision wrong in Uganda, it was slightly more than 50% of GDP. But, we say in health economics, the results are robust to assumptions. So typically, we're pretty confident that we can safely say it's cost effective. How does this differ? when we were getting ready to do this study, we read through the literature. Typically, maternal health cost effectiveness studies look at, like WHO or World Bank will look at doing clinical intervention compared to doing nothing. On the other hand, there's field studies which typically look at a single intervention. So are transport vouchers cost effective? I think this is unique in that it's the whole package. It's all three delays. It's a health system strengthening approach that we've assessed all together. And I don't think that, to my knowledge, that hasn't existed before.
Claudia?
We called it costing the whole enchilada.
So we'll have to change it to pesos, you know? Okay. Well, good. Thanks, Ben. So, Marianne, you use the term systems for health, which certainly resonates with me, and I'm sure lots of others. Looking more broadly, what does it take to improve health? The question is, how did this program, what kind of contribution did it make beyond the health area itself? And was there any kind of spin-off effects and things that you saw? And then, of course, for those who are thinking about doing this or looking at programs, what recommendations would you have if you're going to be looking at sustainability? We've heard one is to start up front and to think of sustainability at the beginning, but what are some of the other recommendations around this topic of sustainability?
Great, thank you so much. So during the talk, I did mention a little some of those examples of broader systems for health, the investments in broad facility infrastructure, the investments in outside facility infrastructure like electricity, communication for transportation systems, and the so all of those are traditionally outside of the health system. And I think one of the things that we don't acknowledge as much, especially when we're thinking about partnerships and sustainability, is how some of those services were provided by the private sector. And when you look at private sector provision of services, you're actually, creating jobs for folks. You're creating a livelihood. Many of the midwives in, many of these districts, were sole proprietors, of their businesses. And, the Merck for Mothers partners worked with them to increase their capacity of their business. So when we look beyond health, I think that there is an ability, especially at the ground level, to include non-health private sector partners to do that non-health system strengthening. To your second question around what do you think the potential success drivers of sustainability are, I do think that the partnerships is a key driver. And I say that because when you have a variety and a diversity of partners at the table, you have resiliency. Claudia mentioned that, at some points, there were questions around funding. Different partners may have different interests or priorities. All of these things will change over time. And so when you have multiple people at the table aligned around a common goal, you're able to weather shocks to the system better. Political changes, we all know, when governments change over, you need some partners that can weather that transition for you. So partnerships, I think, are an important part of sustainability.
Good. Thank you very much. So let me just now turn to the audience. I'm sure there's lots of you who have questions, and we have a good amount of time, almost 20 minutes, so we'll be able to entertain quite a few. So again, the rules, hold your hands. We'll call on you, say who you are, your name, and then your affiliation, and keep the questions succinct so we can have more in our discussion. Okay, over here.
I'm Omrana Pasha from the Johns Hopkins School of Medicine. I first of all want to say thank you to all of you, but particularly to Anne, who left her newborn to come here. Thank you so much. And my question is also to you, Anne. You used a phrase which I am just in love with, little p partners and big P partners. That's such an important idea to think about, and I'm so glad that you emphasized it. I wanted to find out from you what you thought was the difference in being little p versus big P in terms of in-country partners and out-of-country partners, and where things stood, where the power dynamic stood between those partners who are in-country and will drive sustainability in the long term versus the international partners.
So you've hit on one of the key findings from this paper is that generally the big P partners were considered the partners represented on the governance structure that were global partners, and they were influential in setting agendas and providing resources. The little P partners, and this is actually a phrase that came up in interviews. Partners on the ground in country, they weren't as represented in the governance structure. However, they had their own level of influence and power by virtue of being on the ground and taking the resources and implementing activities. Would it be a stronger partnership if there was more representation of these smaller P partners in the governance structure? Potentially, yes. But I don't know. I haven't seen it in the literature done before. I think the way this partnership was set up is with the big P partners represented in the governance structure and little p in the field is common. So I don't know how it would work.
Maybe if I could just add one comment here is, I think early on, because of that big push, there was a lot of focus at the global level. But over time, we did include the country programs in both our calls out, the government's leadership council calls, as well as when we met overseas, often once a year, that we would have all of the different partners there engaged. So we were reaching out to them to make sure that they had a bigger voice than early on. So there's kind of a maturation of this relationship over time. So, okay, another question back here.
Thank you. This is for The Economist, and this is not
your name and
my name is Laurie Krieger from the Manoff Group, but this is actually a question from Dr. Mohammed Al-Farali, who's an independent consultant, because I don't speak economics. So when you calculated the life years and the cost, were you calculating it based on the average? And you said the average life expectancy of 69 years, but were you calculating the fact that the women had already lived a certain number of years and there's an average age of maternal death? We know it's low and it's high. So you're only calculating the number of years expected to be left? And how did you do that?
Let's see, who should take that question on the panel? How about Ben?
What about just yes?
So yes, we account for the age of death, and there are life tables that give the life expectancy at different ages.
Okay. Here in the middle.
Thank you. My name is Emir Rurangwa with Project Concern International. I was so happy to hear from Dr. Mary Ann Etiviet that social norms and culture was considered into the sustainability piece. And I missed to ask my question in the first panel, but one of the reasons why women would prefer to deliver home versus facility is the fear of a C-section. Earlier, they presented results that was a key indicator of the impact of this project. The number of C-section has gone up. As health professionals, we're happy to see that. But for women who have that fear that if they go to the hospital, they'll have a C-section, how did the project do that, change that perception? Has that changed at all? And how sustainable that perception, has that behavior changed, and is it sustainable?
So thank you so much for the question, and perhaps I can answer generally and see Claudia can answer more specifically. I think that people do things for a reason. So women don't go to facilities either because they can't or they fear, as you mentioned. And if you think that facilities are where women go to die, then you're not, you're going to want to reduce your chances of death and not go to the facility and die. And perhaps, again, I don't know this because I don't know if it's specifically been studied, but when women may have complications and C-sections are attempted and the outcome is not positive, then there may be an association, between death, going to the facilities, and C-sections. But I think your question is critical because we need to be able to understand, those norms and those cultural understandings. And we need to work with women and the communities to unpack them and create a new environment for the creation of new norms so that going to a facility is thought of as a positive and life-affirming decision and not a decision that's putting you at risk. And I do think that one of the things that SMGL taught us is when we do improve quality in the facilities, we increase the demand for facility births. And so at least from that indicator, we can assume that we did change some of those normative understandings. Claudia, anything to add?
No, I would just say that, at some level, we're at a disadvantage. We have aggregate data about C-sections. We don't actually know, or it's difficult in this kind of a situation to find out if each individual C-section was medically indicated, and that's the name of the game. There are classifications that allow, in some instances, to indicate whether they were or not. But we've had to go simply by the level of the population level of C-sections. And we have been below the recommended, I hate to use the word recommended, the acknowledged levels at which WHO says C-sections are probably necessary at a population level. So we would have to go into each individual case and see whether or not we thought they were medically appropriate. But of course, that's the Holy Grail. Thanks for the question.
Okay, so here.
Hi, thank you so much. Lisa Nichols from Apt Associates. I had two questions I wanted to ask. One was about the partner, the community, because I know many communities support financially and in kind, and many of these health centers aren't sustainable with the funding from the central level. So I wanted to know more about the contribution in the communities and how that was factored in. And then my second question, in both countries, what's being done about cost recovery? Because sustainability, certainly, I know, Robert, you were just in Mali, and Mali just declared free services for children under 5 and pregnant women, but we know that nothing is free, right? So I'm just wondering if cost and the consideration around subsidizing cost and cost recovery was part of the SMGL approach. Thanks.
No, you can.
Thank you. So in terms of the cost recovery perspective, I think, as I mentioned, there's a finite budget. It has to be allocated. I think that what we can perhaps do to change that paradigm is to talk about how do we increase the pie as opposed to fighting over the slices within the pie. And I do think that the role of private sector can help with that, because I think if we think about how is it that we create value, whether it's through innovation, whether it's through capturing the value of local private sector that was not originally conceived as being part of that pie, whether it's about bringing in new private sector capital that can help finance some of these things, again, increasing the pie, we can start to have a different type of conversation around cost recovery because we're not fighting over slices, but we're all of us thinking about how is it that we increase the pie.
Yeah, and to respond to your question about how's the community considered, I think one question I would ask back is, I would wonder what our definition of community was. The interviews with district health officers revealed a lot of that they spoke a lot about the support that their districts provided independent of the SMGL partnership. And at that was the level at which this study engaged the community voice. However, one comment that really stands out from Zambia was that that what they were able to continue to provide, they could continue to influence regular care, but they were asking the partnership to supply things like operating rooms or vehicles, transportation, and they said we're more than capable of continuing to provide these services. We just don't have the big cost items.
Okay, next question. In the back.
Thank you. Hi, I'm Vandana Tripathi with the Fistula Care Plus project at Engender Health. And this question might be more suited to the first panel or to you folks. I know the emphasis was mortality, saving lives, and the impacts are really profound. I think we also know that as maternal deaths and even newborn deaths decline, some proportion of those become morbidities. And some of those morbidities may be quite severe, may have long-term impacts on quality of life, disability. So I'm curious if you were doing this again, or if you're advising those who are implementing similar systems-oriented efforts, how can we advocate for, how can we make more feasible measuring morbidity? Would you do it if you were doing this again? And if you were wildly guessing, what might be some of the cost-effectiveness results you could find if you're able to incorporate morbidity? And I'm also thinking not just about the morbidity that was alluded to, for example, in newborns who survive obstructed labor, but also morbidity that might be iatrogenic when we have more and more cesareans in facilities that may not yet be ready to provide that quality of care. So thinking of morbidity quite holistically. Thank you.
Ben, do you want to?
Not really. So I'm going to punt the would we measure morbidity in the future? Yeah, I would if I could. But in terms of the cost effectiveness, so I think inevitably there were morbidity reductions with SMGL which weren't captured. So to the extent that they address morbidity already, it would make the cost effectiveness more attractive. In terms of adding on more activities to specifically address certain kinds of morbidity, I don't know. That's my honest answer, unfortunately. Yeah.
Marianne?
So my short answer is yes. We need to do it. When we do it, we actually see the rates of maternal morbidity increasing. It's not enough just to have women survive. We must make sure that they're healthy over a lifetime and think about quality of life over a lifetime. I think that the work that there's more work to do in terms of how do we create systems so that we can capture morbidity more easily, and how do we actually simplify, some of our measures so that it's actionable and not just, complicated and people, raise their hands up and run away. So, I would like us as a community, to move towards being able to measure morbidity and look at quality of life and well-being holistically.
I wanted to just add one thing relevant to the overall partnership. Something that came out in our interviews was that a strength of this partnership was that it had a very specific targeted goal. And so the more you dilute that, I don't know what would happen overall to the effectiveness of the partnership. So it's just something to think about when you're weighing what are we trying to do? Morbidity, mortality, et cetera, and what interventions.
Mm-hmm. Can I add something to that? I think you're right. And that's why this health system strengthening approach or the system strengthening approach is critical, because we cannot create a new system every time we have a new metric that we want to measure. We need to create systems that can measure a range of metrics, over time. And then the other thing I'd like to add around this point about morbidity, many of, you talked, Mary Ellen, trying to advocate for funding for maternal health. We are still in a place where focus on maternal health and prioritizing maternal health funding is shaky. And I think that the more we can do to be able to tell the story that investments in maternal health actually improve broader health outcomes, chronic disease outcomes, the better we will be able to continue to secure the necessary funding and investments we need to save lives.
Okay, we have one question that's come over the Twitter, and it's really looking at the whole issue of working with additional programs. So the question is, how do organizations working in these countries more effectively collaborate with governments, implementers, and donors to effectively utilize existing resources, expertise, and systems in additional programs to continue accelerating gains? So in some ways, broadening the partnership out to other activities beyond SMGL to make sure that we are continuing to work on these issues. Any thoughts from the panelists?
My processes are slow because sleep deprivation. But one thought I have is that that came up in our interviews was that the ability of SMGL partnership to show by example their success led other partners down over the course of the 5 years, other local organizations and global organizations, to want to join in and carry some of the partnership load. So I think having the strength of evidence that was part of this particular initiative was critical for them.
Mm-hmm.
Mm-hmm.
I think it's a very interesting question and relates to the big P, little p question as well. At some point, too many partners become unwieldy. And so how if it's a top-down approach, but I think that if it's a bottoms-up approach, and there are those systems for collaborative decision-making and implementation, you can't have too many little p partners to use the term. Yeah.
Okay, so we've run out of time for the question and answers. So I would like to thank the panelists for illuminating us on these issues of partnership, cost, and sustainability. I think very important to the future of this program. So thank you very much. And now to wrap it all up and to send us away with a good vision, Dr. Barbara Levy, who's a vice president of the health policy and administrators at ACOG, will have our closing remarks.
Well, wow, that was exciting, exhilarating, and an awful lot of work. So kudos, Claudia, to you, to the grand vision, and what an amazing amount of work. So applause to everyone. So I've been sitting here this morning trying to pull this all together into sort of a big picture, and several things come to mind as I try to synthesize. The first is you have to have a vision. You have to believe in something, and then you have to have a champion. And Claudia, you were a champion, Lois Kwam was a champion, Secretary Clinton was a champion, with a vision that we could have some impact in maternal health, even though we didn't have the data, because women are complicated. And we don't have data in almost anything that I work with every single day. And until we take on that challenge and understand that the world is complicated and create new systems for data to be able to measure what it is that we're doing, we won't be successful. So the concept that there was a vision and a champion and an ability to leverage that, to leverage a platform that already existed, the PEPFAR platform, and USAID, to get us moving and going and to do something was just critically important to all of this. The second thing as I was listening is that I hear the outside in. We had this global partnership on the outside going in, but we also had then to leverage the partnership from inside coming out. And when we think about systems, there are two levels of systems. There's the big capital S system that is transportation and communication and electricity and all of those things. And absolutely, we need all of those things. If we don't have them, we will not be successful. But there's also the health system or the facility itself. And how do we change the culture there to provide respectful care, to be responsive to the needs of the community and of the people who access care there? So I think that it's not only the fear of a C-section, but it's the fear of that disrespectful care, of violence during childbirth that prevents people from wanting to come to a facility. And that's not just in developing countries. That's in our own country here in the US. I mean, we have similar problems here. So another big theme that I thought of is something we've talked a lot about at ACOG, and that's things are global. You know, they're global and they're local and they're not dissimilar in rural US and the inner city here in Washington, D.C. than they are in Mali or in Zambia or in Uganda. So we need to be thinking more broadly about systems, about culture, and the fact that we are a global community and that many of these same systems and problems are universal. And how do we take that and begin to move the needle and change that and put women at the center of what it is that we're doing? Not hierarchically, but listening to women. You know, your qualitative research is very, very important from the standpoint of providers and the partners, but it's also important from the standpoint of the people that we're serving. And how did they perceive, you know, what it is that we're doing? That trust. I didn't hear that word, but I heard the concept that the communities, the folks, the tribal leaders have to trust us and trust that the interventions that we're recommending are meaningful and will impact their families and their economics and their culture and their community. So trust, I think, is a really important theme that we need to remember. I totally agree that culture change is what has to happen for anything to be sustainable. And you all know that we've got a rising maternal mortality rate here in the US. And, you know, ACOG is involved in a large national project to try to change that. And we're focused on very similar things, and it's all about trust. You know, we started with what we know, because we're ACOG, we're healthcare providers, so we know what happens in the hospital, and that maybe that's postpartum hemorrhage and hypertension. But the inequities in outcomes in the US and the inequities in high-income, low-income places, either doing too much or doing too little, are things that we have to focus on and try to impact. So those are themes that kept coming back to me. I think we have to be creative about how we're doing things. The innovation, the systems that SMGL brought to bear were incredibly powerful, and a new way of looking at things. You know, we got rid of an awful lot of your vision of getting rid of some of these silos and providing contraception and HIV care and antenatal care in the same facility by the same provider is a key to making all of this work. But what I'd like for us to think about and to think creatively, because we know the resources for MCH are limited, because overall women don't count in our societies, but there are other efforts in countries that are sexier maybe to leadership. So there's a whole effort to reduce deaths from trauma. There's the surgery obstetrical trauma and anesthesia program. Zambia has a nationwide vision and program for what they call SOTA. But the O in SOTA has been visibly absent. Nobody's paying very much attention to the maternal child health piece of that. And yet, there are more births than there are traumas. And if we had a system in place that was structurally set up for safe obstetrical care, and it had anesthesia, and it had operating rooms, and it had transportation, and it had electricity, then you could manage the traumas without too much difficulty. So I think we need to be thinking even bigger about integrating ourselves into these other things that are going on in countries where perhaps there's more power because it impacts men, at least as much as women, which is not to say that I don't think we should be empowering women and that we should be focusing on that. We should, but reality is what it is. And if we can leverage what's out there for other systems and programs, we should definitely do that. So I think expanding and thinking about those other things is really, really important. As I think about approaching our work, a quality improvement framework comes to mind, and that is that, you know, we've got structures we need to work on. We have processes that we need to work on to get to the outcomes that we want. And then we need the data surrounding all of that so that we know what to do. But if we build a structure and we don't have the processes, or we have the processes but we don't have the structure, we're not going to get where we need to go either. So that's another framework for us to think about. There are basically 4 big areas. You know, one is the SDGs, of course, and trying to get the maternal mortality rate down from the several hundreds to 70, which is our goal. Obviously, in this country, our goal is to get rid of the rising rate and at least stabilize it and reduce inequities. That's another big thing. It's complicated, and as the rates go from 500 to 250 down to 100 and then to 70, the challenges become bigger. They're bigger. I mean, so we get people into facilities. We've done a great job with that. But then what's the quality of the care in those facilities? And what's the workforce? What's their training? And how do we do that sustainably? So I think that's a big challenge in the next 5 to 15 years, is creating a workforce that can not just do the emergency things, but can do all of those things in a respectful and high quality way that gets us not only reducing mortality, but also morbidity. to your point, you're exactly right, that if we're doing C-sections faster than we can do them, but we're cutting ureters along the way and creating fistulas, that's not where we want to be. So I think focusing on those things we need to do to get the rate down to 70 is more challenging, but we can do it. We can do it. I think universal health care, we've got to have care for all. And I won't go into long detail about that, but that's as big an issue here in this country. Access to care is critically important. Gender equity, critically important, and the respectful care. So those are the places that I would love to see us focus. We should celebrate what we've done here. I mean, the outcomes are unbelievable, and who would have thought we could actually get close to that 50% is amazing. But we need to take the successes and build on them. There was lots to learn. The sustainability, the funding was a huge issue for us, but that trust. I think the central word I'd like us to leave with is trust, trusting in our partners, trusting the communities, and earning their trust in us so that we can be successful. So thank you.